Hi, my name is Marissa Benson, and I am a master's level graduate student at the University of Texas at Arlington College of Nursing and Health Innovation. And this is my comprehensive strategic and marketing plan for the University of New Mexico Hospital for Nursing 5342, Management of Nursing Operations. University of New Mexico Hospital, it's the only level one trauma center in the state of New Mexico. It's also the only academic medical center in the state of New Mexico. About 63% of our payer mix is Medicare and Medicaid, meaning that less than a quarter of our insurance is private, of our patients have private insurance. It is also physically located within 2 miles of our nearest competitors. With the point that I'm trying to illustrate here is that the patients that come to UNMH come here for our skill level and the services that we provide. We have other competitor hospitals within the area, but there's not really like a competitor market because of the nature of New Mexico with a very diverse population, but it being more of a poorer state with fewer resources, as demonstrated by the fact that 63% of our payer mix is Medicare or Medicaid, meaning that many of them don't really have an option, that UNMH is where they have to come to get their care, um, which I will be emphasizing this a little bit later in my presentation. So our patient care delivery model, UNMH provides patient care in a team nursing model, working collaboratively with numerous different disciplines. The focus of patient care at UNMH is focused around the unique needs of our patient population. Again, the only level one trauma center, the only academic medical center. This means that we have a very diverse population, and we have to meet the diverse needs with the services that we provide. We have to expand the services that we provide. We are the highest level of care in the state, so patients have to come to us. The patient care delivery model at UNMH is to provide patient-focused care. So even though patients don't often have a choice but to have to come to us for the services that we provide, we still want to be able to provide care that is centered around patients and their cultural needs, their diverse needs, as well as their physical and psychosocial and emotional needs. So for my strategic plan, in October of 2025, we opened the new critical care tower, meaning the hospital now has three separate towers to provide patient care. It's ever expanding. In the old Pavilion Tower, there were three adult ICUs, and now the question is, what do we do with these adult ICUs? Within the hospital, our formal reporting has us at 96% capacity for most of the time. Internal reporting shows us that we are greater than 100% capacity for our adult inpatient population. Often we are averaging anywhere from 105 to 120% capacity between the emergency department and adult inpatient units. My proposal is that we create an ICU step-down service line where we provide care for patients somewhere between ICU level of care and our progressive care units. It would provide 1 to 3 patient care ratios. This would essentially be a bridge between the PCU and ICU, as well as long-term care and discharge. Often patients are ready to get discharged and out of the ICU, but are not necessarily ready for the next step. And sending them to a progressive care unit where the patient care ratios are 1 to 4 or 1 to 5 does not really allow them the time to get the patient-centered care that they need and the 1 to 3 nursing care that would really help them to be better prepared for either long-term care or discharge home. So as a part of this strategic plan, I would want to use one of the old ICU units and open a 24-bed ICU step-down unit. This is where we could physically locate these ICU step-down patients. The unit is already there. They've already been taking patients there. They're already single occupancy rooms, and they already have the infrastructure necessary to take care of these patients. All that we would need to do would be to renovate it to make it more friendly to our patients that might be a little bit more mobile than our other ICU patients. We would also need to make sure that everything is up to code, just by nature of being a building that's been in the hospital for a while. There might be more standards that we need to meet, so we would need to close the unit for a bit of time before we were able to open up to the ICU step-down units. For the marketing plan, as I mentioned before, our payer mix is over 60% Medicare, Medicaid. So the goal with our marketing plan is really to market to outside talent. We would need to fill a director position first because that person would need to make all of the hiring decisions for the nursing staff, support care staff. We would also need to market to our advanced practice providers. We would have our critical care APP director hiring those as we would have our critical care APPs taking care of these ICU step-down patients primarily. Our goal is to attract qualified staff and retain staff with a specific skill mix. Often I find that there are staff that don't necessarily want the adrenaline rush of the ICU, but they do want some more stable patient population. And this ICU step-down is the perfect niche to give both nurses and providers a different patient population, a specialized patient population that they can learn a lot from and focus on and really put the care that they need to in without having to get as extensive as the ICU and without having to be as overwhelmed with so many patients in a progressive care unit. I did find a couple of studies that showed that there's not a ton of research into step-down units with these 1-to-3 ratios and how they can impact the hospital's bottom line. But what I did find is that there were significant improvements in quality outcomes and patient outcomes and quality metrics. So I think there's a real opportunity there to provide a service to our patients to improve their outcomes, particularly since it's such an underserved population. And I do believe that the patient satisfaction scores will follow. Again, because we're not really in a competitive market the way some other hospitals are, patients come to us because they have to. And so what we want to do is we want to create providers that want to work in our hospital. We want to create an area where the nurses and providers want to stay. And having them stay there will have them really be passionate about their work. And being passionate about their work provides passionate care. And then they'll be in a place where they have the time and energy to provide that care to our patients. This, I think, will show itself in our patient satisfaction scores. I think this will also show itself with patient loyalty and with word of mouth. I think that having patients that maybe would have been at our competitor hospitals but got into a really bad car accident, had to come to the ICU, then had to come to our step-down unit, we can make the difference in their care. And that's the way that we're able to convince them that maybe they want to come back to us because they received such excellent care with us that first time. So service line and volume projections. So this is a 3-year plan. It will be a slow start, but the projections will increase as the service line and patient populations grow. I do also anticipate that this will grow as nurse and provider comfort and skill level grow. And then I think that once nurses and providers have more comfort with this patient population, I think they will be able to expand the list of patients that we're able to take and expand the scope of the patients that they can take. So these are my year 1 projections. In the year 1 projections, I anticipate about 9 months of the units still being closed just for renovations and getting the building up to code. I anticipate about the last 3 months of year 1 having a census of about 12, just while we were probably still be getting nurses hired and providers hired. And this is the projected revenue that I have with about $2,000 per day of reimbursement expected for these patients with 12 patients over 30 days. For year 2, I anticipate that the beginning of the year would have an increased census of 24 beds. It would be the winter months, which is specifically when we have our winter surge. I would anticipate a drop over the summer months as our winter surge dies down and our respiratory illnesses kind of die down. And then again, I would expect another increase at the end of the year for the winter surges. During the summer months, I would anticipate a census of about 12 to 22 patients a day. And then during the winter months, I would imagine a census of about 24 patients per day. For the year 3 projections, I anticipate a similar patient population, patient size as we did the year before, with the exception that for year 3, I would anticipate that the nursing staff and providers have really kind of honed in on their skill and they've honed in on what it is that they're doing and the patients that they're taking, so that I imagine during the summer months we would have expanded the patient lists and patients appropriate for us. So our average daily census would have increased to about 16 to 22 patients per day over 30 days. And again, all of these are imagining an average reimbursement rate of $2,000 per day per patient. So, in summary, at the outset, this is a time and money investment. It does not seem lucrative initially. I think that we can acknowledge this. Healthcare right now is not a very lucrative position to be in. However, UNM Health needs investment and time for this growth opportunity to demonstrate the impact. As I mentioned before, our population is so underserved. And the way that we are going to attract our population isn't going to be the big shiny new things, although that is nice and we do still strive for that. How we're going to attract them and help improve patient outcomes and our outcomes is by meeting patients where they are at and meeting where their need is. And really, their need is for an ICU step-down unit to both offload the ICUs, as well as giving them a bridge between the progressive care units and home and long-term care. So this has a potential for far-reaching and lasting impact with nursing and provider retention, improved patient outcomes, fewer readmissions, and a better transition to long-term care. Thank you so much.